We are live now, sir.
Yeah, okay. Hi, good evening, everybody. We welcome all our viewers to the ASSI and BAS collaborative session for working towards the ASSI conference in January 2024. Today, we have the members of the British Association of Spine Surgeons. I'd like to welcome the president, Mr. Aprajay Golash, the secretary, Mr. Rajat Verma, and all our speakers, Dr. Lennel, Dr. Vinay Jasani, Dr. Kaushik Ghosh, and Professor Sajan Ahuja, and also our past president of the Association of Spine Surgeons, Dr. Shankar Acharya. So we have an excellent session, and the topic of our session today is going to be related to junctional instrumentation and problems related to that. Now, I would like to ask Dr. Shankar Acharya to welcome and start the proceedings.
Good evening, everyone. Thank you, Dr. Balamurali, for introducing me and Ketan. And welcome all the overseas faculty. It's great to see Dr. Sachin and Rajat and others after a long time. And it's a pleasure welcoming you to the ASSI BAS session. I'm sure this is a special session because the topic is special and junctional problems are always a big issue of concern as to long-term outcomes. And I hope our participants who are live online will all benefit from your knowledge and experience. Thank you so much and welcome. I look forward to hearing the deliberations during the next hour and a half. Thank you. Over to you, Ketan.
Good evening, good afternoon to our friends from Britain, and good evening to our Indian faculty. I welcome you all to this webinar on junctional spine issues, the biomechanics instrumentation. And as we all know, junctional areas offer a big challenge because of the change of biomechanics, change in anatomy. So I welcome you all on behalf of the Bombay Spine Society, of which I am the president at present. And Bombay Spine Society is hosting the annual conference of the ASSI, the Association of Spine Surgeons of India, this year. That is the 2024 the 2024 year conference, and this to widen the horizons of ASSI and to shake hands with all the different societies in the world, spine societies in the world. We devised these webinars. These webinars are a way to reach out to all our friends and experts in other areas of the world and have joint session of discussion on interesting topics. And this is in a way ASSICon before the actual ASSICon. And these besides being played live at present, they are recorded and they'll be relayed during the time of the ASSICon. So people who would like to revisit or even who have not got a chance to see these webinars would be able to see it. So I welcome all the faculty from the British Spine Society and our Association of Spine Surgeons of India. And I hand over back to Dr. Rajat to start the proceedings, the academic proceedings. And I'm sure this is going to be a very interesting, very knowledgeable, a lot of take-home messages from this session. Over to you, Rajat.
Thank you very much. I'm very excited with this because I think our president, Mr. Golash, one of his visions when he took over the presidency of the British Association of Spine Surgeons was to widen horizons, and it's good to see that similar thoughts are being echoed in the Association of Spine Surgeons of India. I will be coming and joining you for your meeting in Mumbai, so I will not speak too much here and take too much time. I would like Mr. Golash to say a few words, and then we can hand over to Bala, who can then start with the first talk. Go ahead, Mr. Golash.
Rajat, thank you so much. And first of all, let me thank ASSI to invite BAS to share this session. Knowledge always increases by sharing. And I'm sure by sharing the way we do things, either in a similar way or different way, will enhance each other's knowledge and capabilities and thereby help the patient care. So I'm looking forward to this excellent webinar that's being organized. And let this be the beginning of our collaboration because I can see a lot more events and a lot of reciprocal arrangements can come in future. So over to you, Bala, and then let's look forward to this.
Thank you, Mr. Golash. Without much delay, we will invite our first speaker, Dr. Lennel, Lutchman, and Dr. Girish Swamy from UK to talk on craniocervical instrumentation and challenges. You can now share your screen. So the way that we will do is that after each topic, we will take about 3 to 5 questions, if we can finish within 5 minutes. And then if there are more questions, we can come to the end. So if there are any questions for the viewers, you can please post your questions in the chat box, and I will note down these questions and I will ask on your behalf.
Thank you, Bala. Thank you for the introduction, and it's a great privilege to speak to you. I follow the Indian literature very closely, and I've had the privilege to hear many Indian spine surgeons speak, and your experience is vast, and it's a privilege to speak. I hope I can make some small contribution from our experience here. I work in Norwich, which is in the east of England, and ours is one of the oldest populations in the UK, with the average, a very high average age. And we come across instrumentation of the craniocervical junction not infrequently. What I'd like to cover in the 15 minutes is a brief background of the procedure, our indications, and what I think is critical for this operation, like any spine surgery, is our pre-op planning. And particularly with this operation, our positioning, it is crucial that you position the patient correctly. And I hope I hope that we can cover this. The approach is important, and then the instrumentation and the closure.
Sorry to interrupt. Could you make your screen full screen?
Yeah, let's try that. I thought it was. Let's if I double.
If it's not working, that's fine.
It was full screen earlier. Let's just try here.
Then I'll click that icon again. What you had?
This one here.
Yeah. Click it again. It should work. Click it again. It should come.
Is it just sort of playing up a little bit? Let me just try up here. Slideshow from beginning. Is that still just a reduced screen?
All right. Yeah.
What about this one? Is that a full screen now?
No.
Okay, let me try sharing. Let me stop sharing, and I'm going to come back to share screen, and I'm going to go for.
So make it full screen first and then share.
What about this one? Is that full screen?
Yes.
Yeah.
Well, yes. Here you could go down to the left-hand corner.
Left corner, yeah.
Yes, I think, yeah, that one maybe try, or.
Because is it showing the preview screen?
Yeah, it's showing the preview screen.
It was working before. These things are great, aren't they? 1 second. Stop sharing. Share again. What about this one? Is that the preview screen still?
No, perfect.
No, this is better.
Full screen.
Yeah. That's better. Okay. So you just got the full screen now, yeah?
Yes.
Yeah.
Thank you.
Okay. Thank you very much. So that's the plan. One of the first things to say about the occipital cervical approach is how extensile it is. When one is operating at the front of the cervical spine and the cervicothoracic junction, clearly one is limited by access. But one of the things I like about this, and it's my bailout for many difficult cases, is it's very extensile. So this is a patient of mine who had a 3-column fracture through C6, which we've stabilized. And because it's an extensile approach, it lends itself to a great deal of stability. Like I said, we often dealing with older patients with osteoporosis and poor bone quality. As a starter, I found this article in the European Spine Journal last year, and it's a review of 128 patients with 5-year follow-up. Many of them were historical, but I want to show you the takeaway message from the paper. 6 people died within a month. And it's also our observation that we're operating on people who are quite fragile. They've got multiple comorbidities, and like I've said, they're elderly, and they've got trauma or tumor or infection in the upper cervical spine. So mortality is not infrequent. 52% of patients in this cohort had a complication. And you'll see here that the most common was implant related, and wound problems accounted for 25% of the problems. So it's a good operation. It has a broad range of indications, but it has a high complication rate in the published literature. And the reason I like the approach and the approach to the instrumentation is that it has a very broad indication. These are all my patients. This man had upper cervical, you see he's got cord compression at the cervicothoracic, the occipital cervical junction. This is a patient with plasmacytoma and instability pain of C2. This is another patient with an extension teardrop type injury, a 3-column fracture through the C2, C3 region. And this is a patient with a unrecognized malunion of an all odontoid peg fracture. And this is a great utilitarian approach, which can, at least in my hands, can deal with all these pathologies. Having worked out that this is the operation that you want to do, then obviously preoperative planning, like I said, in any aspect of spine surgery is important, but particularly in this operation. We sometimes use plain radiography, and invariably we'll get a CT scan, including the skull. And the reason is in patients with tumor, say example, multiple myeloma or plasmacytoma, you need to make sure that the occiput is intact. It would be very embarrassing to approach the skull to try to fix a plate to it when you have deficient bone, either from an acquired or congenital cause. MRI scan is obviously crucial, and in certain instances where the MRI is worrying, one might undertake vascular studies. The aberrant vertebral artery is the thing that we would all worry about. So looking through your CT and your MRI scans preoperatively to try and plan the instrumentation is crucial, and looking in particular for any aberrant vascular anatomy. This, I think, for me, I've learned a lot of lessons, some harsh lessons in positioning patients for this procedure. This is one of my patients. This is the lady with the extension injury through C2, C3, who presented with a complete high cord lesion. Because she was unstable, I opted to stabilize it using an occipital-cervical fixation technique. The positioning is crucial because if one positions the patient with the neck in abnormal flexion or extension, or the neck is protracted or retracted, the head and neck are going to be fixed in that position after the procedure, and there is no ability of the subaxial cervical spine to compensate for any significant malalignment. So this is an instructive case. Before I come on to that, I was looking at the literature regarding problems with positioning of the head and neck. This paper from Dysphagia looks at the angle of the base of the skull relative to the base of the C2 vertebra. The long and short of it, forget the angles. If you fix the spine in flexion, you can cause dysphagia because the patient cannot swallow because of the flexion posture of the neck. And this is an example here where they've done occipital cervical fixation with the neck in flexion. And you can see the angle between the base of the skull and C2 compared to the normal. And when you rectify that angle with a revision procedure, the patient's dysphagia was resolved. And unfortunately, I have personal experience. I love it when you hear people talk and all their revision procedures had surgery some other place by some other surgeon. My revisions are my revisions. So this is the preoperative CT scan showing the distraction injury, extension distraction type pattern. And this is the position that I fused the patient in. And you can see that I've flexed the neck and the spine. The intraoperative imaging did not give me enough clues. And I have to say, I wasn't diligent enough in recognizing it. And when the patient woke up, she had dysphagia. It was easily remedied, but embarrassing to take her back to theater, to take the rods out, realign the spine and put new rods in. But it's an important lesson to me. I've done a few of these procedures, but still, spinal surgery is such that if you take your eye off the ball, you're going to get into trouble. So looking at the optimal position for the head and neck when you're fusing the skull to the cervical spine is crucial. The having positioned the patient and looking at the patient from the side, looking at protraction, retraction, flexion, and extension, looking at the head and making sure that the spine is not rotated. The approach, I put the patient head up to decrease venous congestion. I infiltrate the skin with local anesthetic, and as we all know, the key is to keep to the midline. If one strays off the midline into the muscles, you experience quite a lot of hemorrhage. And then, as is quite straightforward, one does a subperiosteal exposure of the occiput and the relevant section of the cervical spine. One of the things we try to teach our trainees is when you're working in the lower part of the wound, release the retraction in the top part of the wound. As I'll allude to in a minute, wound problems are not infrequent. And as we saw from that ESJ paper, 25% of patients with a complication had a wound problem. The screw cascade is important. I'm jumping ahead here because I know many of you, I know I'm speaking to many experienced surgeons. I always find that insertion of the C2 screw is always more lateral than the cascade of the other screws. I tend to put my C2 screw in first. This schematic diagram doesn't really represent it, but C2 is often out of alignment with the rest of the lateral mass or pedicle screws. So the screw, concentrating on the screw cascade and making sure that the screws are reasonably aligned is important. And having done the cervical screws, I then put up a rod template, and that helps me to choose the relevant occipital plate. Many systems now have a slotted hole so that this connector on the skull can translate medially and laterally, but some plates are of a fixed size. We try to use at least a 4mm titanium alloy rod, and increasingly, I'm sure your systems are all the same. The rods are often now pre-contoured and require a degree of contouring, but you don't have to put in this 90-degree bend often. Sometimes the systems don't have pre-bent rods, and one does have to contour the rod. Again, one wants to do small continuous bends and try to avoid one side of an angular bend because it creates a stress riser in the rod. Sometimes, despite one's best efforts, the screw cascade is not ideal, and the use of offset connectors can be helpful. The complications of occipital cervical fixation were reported in this seminar in spine surgery by Allen et al. And I've not really had any major difficulties with putting the occipital plate on. I know many people use paramedian screws. I put 3 screws in the midline, and you can see here from this cadaveric work that one should be able to get at least a 10 to 12 or 15, even a 15mm screw in. Clearly, it would be slightly cavalier to not use a guarded drill guide. There are cases in the literature reported of occipital cortex injury or damage to the sagittal venous sinus. But I think by using a careful, gentle, I always start with the 6mm and then gradually work up. And in between each drilling routine, palpating down with a pedicle finder or gently feeling down to make sure that you've not yet perforated the inner cortex of the skull. I think, with due care, this should be quite a safe procedure. Once in a while, one does see CSF, and we all know that the treatment for that is to put the screw in. Don't stick suckers in, and sometimes the very helpful junior registrar can be a bit overzealous with the sucker. I think an important part of this operation is tapping the skull. We'll all be aware that the screws are designed to be flat, and it's a cortical thread. So I think you have to tap through the inner cortex. I think in instances where I've failed to do so, as I advance the occipital screw, it bottoms out and you can strip the thread. So it's important to drill through both the inner and outer cortex, and it's also important to tap through the inner cortex for fear of stripping the threads. There are rescue screws on most of these systems, but your first screw is probably going to be the best purchase you have. So the other tip I would have is always spend time making sure you've tapped adequately. One of the things I discovered with that case where I malpositioned the occipital cervical junction is it shouldn't be that easy to tap all 3 screws. One tends to have to use an angled screwdriver, and you should think to yourself that actually I didn't have any difficulty tapping the lowermost screw. You should be thinking, have I got the occiput lined up correctly relative to the cervical spine? All the time during this operation or any operation, we should be thinking, why is this operation behaving normally, or why is it not normal? But tapping is important. The wound closure is crucial. And again, this is one of our patients who's developed a nasty deep infection. I think closure for this operation should be performed by the lead surgeon. I do it myself. I think reconstruction of the ligamentum nuchae and the deep tissues and the fascia is crucial. And I do so with multiple interrupted sutures. And I also use a continuous suture in the ligamentum nuchae and the fascia. The skin closure I do myself as well. Infection in this context, as in any context with the instrumented spine, is a catastrophe. Bear in mind that just under here, you've got the occipital plate, and you have to make a real effort to get soft tissue coverage over the metal. The one huge disadvantage of this procedure is that there is very little subcutaneous cover for the occipital plate. And we've had one case of a nasty infection which required all the instrumentation to be removed. So the post-operative care and the closure is important. This is one of the few instances where I use topical vancomycin. The patients have induction and perioperative antibiotics, and where possible, I try to stick a vacuum dressing. I use a collar until the wound is healed. And because many of these patients are elderly and they have tumors or they have a high cord injury, I have a low threshold for asking the anesthetist to pass the nasogastric tube so we can feed them enterally if they can't swallow. So in summary, therefore, I like this operation. It has a very wide indication. If I'm planning to do a C1, C2 fusion and I can't get the screw in or I have bleeding, and I think it's a useful plan B for other operations in the posterior cervical spine. And for a C1, C2 fusion, I will routinely consent my patients for the possibility of an OC fusion if I cannot site the screws or if the bleeding I cannot control. As I've stressed, the positioning is crucial, and I've shown an example where I got it wrong. And spine surgery always catches you out and keeps you humble. A midline approach is important with meticulous hemostasis, and try to plan the cascade of screws so that you can get the rod to align with all the connectors. Most systems now have variable size plates, polyaxial screws, offset connectors, and pre-contoured rods. And the other trick is the tubular benders. A standard French bender often cannot get an acute enough bend on the rod, so your set should include tubular benders to get an acute bend on the rod. I've talked about using the drill guide with a depth stop and the importance of tapping line to line to avoid stripping of the threads of the cranial screws. I cannot stress enough that meticulous closure is crucial, and infection in this area is catastrophic. One of the recurrent themes of junctional instrumentation is the nature of the vascular watershed in the blood supply, and I think that's why this is an important topic. Thank you for allowing me to present on this.
Thank you so much. That was a very good insight into the occipital cervical junctions complexity and the difficulties. And thank you for being honest about some of your complications, which we all do face. I think we can start off with any questions from our speakers here. And I'm just waiting if there are anything in the chat box.
Bala, can I ask
Please.
a question of
Please.
Lennel? So, Lennel, you mentioned about positioning. When you position, how do you prevent what happened to that lady with the flexed spine?
Yeah, Rajat,
is it just a naked eye view? Do you take X-rays? Do you ask somebody else to see how would you stop this happening again?
Yeah, good point. All those things. I try to transfer the patient with the collar on to try and maintain the alignment of the spine. I remove the collar and I look from the side. I get plain radiographic views. And I think in retrospect, what I can see looking back at the II imaging is that the occiput, which should be about 30 degrees tilted to the horizontal, was more tilted. And I also got a colleague to come in and I said, can you have a look at this for me? I'm not sure. And, I'll never let him forget that he said, yeah, it looks fine. So I think the important thing is to have a high index of suspicion, transfer with the collar, check frontal, check from the top, check radiographically, and ask a colleague to check. I've tried various things over the years, like trying to measure from the sternal notch to fix bony landmarks. I think just a few degrees makes the difference between success and failure. So in answer to your question, I think you should use all of those strategies.
Thank you. I think, Mr. Golash has his hand up.
Thanks, Rajat. It's absolutely critical, as you just said. I think the key thing is before you drape the patient, it's very important that you come away a little bit and then look it from the side, because many patients are not on a collar because they may be an elective you're brought in and you can end up with a problem. So if you don't have a collar or something, X-ray, CR, high suspicion is the first thing. You must be aware that this possibility exists and causes trouble. And secondly, looking from away, just a ballpark usually works out. So before you drape, you
usually, yeah. I've had one senior colleague when I was a fellow. He fused the patient with the neck retracted, and the patient couldn't be extubated. So you can get airway obstruction if you put the neck in a retracted position. So the patient had to be hurriedly reintubated, brought back into theatre, and the position adjusted. So all I would say is the crucial thing I've learned is that positioning. And I think the closure is the other thing I tend to stress. I think the lead surgeon should close the wound, as arduous as that might be sometimes.
Can we just can you move on? Is that okay?
Yeah.
And I know it's just, Vinay, do you want to share? I just would like to introduce Mr. Vinay Jasani. He's a consultant colleague and a very close friend of mine. Does a lot of training and teaching, has led and trained several spine surgeons in the UK and abroad. Vinay, over to you.
Thank you. Thank you, everybody, and thank you for the opportunity to discuss this topic. Can everyone see everything, hear everything all right?
Yes, perfect. Yeah.
All good, excellent, okay. So my remit was to talk about C1, C2 fixation, and I'm very aware that the audience I'm talking to is probably as much experience in C1, C2 as I do, if not more. But just to run through things, just as an overview about C1, C2, and perhaps what I've learned, etc. So I think the cranial-cervical junction is quite an intriguing part of the spine. So not only is it transitional, which is what I guess the theme of this whole discussion is today, but it's also got the weight of the head to deal with. And it's also a very mobile part of the spine. So as you all know, the upper part of the craniocervical, the upper part of the cervical spine is 50% of the motion for the head, and that's fairly important. So I'll be honest with you, I think in the days gone by, we thought that because it was so mobile, because we got the weight of the head, and because it's transitional, we needed to do very extensive fixations like we've got there in order to try and make sure that we stabilize any problems at the C1, C2 level. But I think we've moved on from that quite a lot, and that's been thanks to some pioneers in fixation techniques around C1, C2. So we're definitely now have an emphasis on preserving motion and preserving function, and actually trying to keep things as short as possible and as simple as possible around the C1, C2 if the pathology is appropriate. And then, as Lennel was just saying, it's also that we want to try and make sure that whatever we do is salvageable. And often that will lead to, salvage situations, maybe craniocervical fixation. But really what we're trying to do is limit things to C1, C2 if we can, again, where the disease is appropriate. So in terms of the diseases we're talking about, so for C1, C2, it's all of them. So basically what I'm trying to say here is, can we limit our fixation to C1, C2? And there's all these scenarios where you probably can. So there's the inflammatory arthropathy patients, so with the atlantic dens instability. You've got the trauma patients with all sorts of fractures, both at C1 and C2, which you may be able to end up doing limited fixation to. Congenital anomalies, so again, that may require some fixation, and C1, C2 limited is feasible. Infection and metastatic disease or primary disease, malignant disease of the spine. So all of these you can consider limited fixation at C1, C2 rather than doing massive approaches and massive fixations. So we started with this sort of a situation. So using sublaminar wiring and a graft, so usually a tricortical graft from the iliac crest, and this is the Gallier-Brook type fusion that we used to do. When I first came into spine practice, we kind of moved on to that, and we were doing this, which is the Margell screw. So that's a transarticular screw going from C2 into C1, and then doing, again, trying to put the bone block at the end because we weren't convinced that just the screw would achieve fusion. And so this is what I came into in terms of spine, limited C1, C2 fixation. And it worked fairly well. So I think your approach is a bit familiar. It's a posterior approach, you're base of the C2, and you're really aiming up towards the C1 tubercle on the lateral view. And more or less, you can get that fixation and transarticular screw. But the problem was non-union, and we were getting non-union, and we were also missing C1 sometimes, and that was part of the issue. And this is where we're at now. So this is the sort of screw fixations that you can do around the C2 and C1. So I just want to run through a few of these. So on here, you've got the Margell screw, which I've just talked to you about. Then you've got the direct screws within C2 itself. So this is what we call an isthmus screw. And so this sometimes can be used in a hangman's fracture with minimal displacement. You can use this screw as a primary osteosynthesis screw, but also it's a really good anchor for cervical fixation otherwise. You've got the true pedicle screw, which is a little bit more of a lateral approach and going down the true pedicle of the C2. And then there's a translaminar screw. So this works really well. I've had this as a get-out screw a number of times, going across the spinous process into this thick bit of lamina. And again, that's a really good anchor. These are just showing the same from a side view. And then there's some intriguing anterior screws. So there's the anterior dense screw, which is often used for osteosynthesis of a C2 fracture going across the waist of the C2. And then these are C1, C2 transarticular screws, which are done from the front. Okay, so these are, again, intriguing. The approach for these can be the same as the approach for this, which is actually a fairly low dissection at around C5, C6, or you can try and get this from a low transoral approach or a transmandibular approach if need be, depending on what else you're doing at the time. So I don't think I do a transmandibular approach just for this. But I think what really came into its own and the workhorse for this sort of fixation around C1, C2 is what Goel and Lahiri described some time ago in 94. So this is the screw going through the lateral mass of C1. And so it's this point A. So it's underneath the lamina. It's just, the original description was to resect the C2 ganglion, which is coming across here. And then that allows a less bleeding around that approach because there is a big venous plexus here which can bleed quite a lot, and then putting a screw straight across the lateral mass, slightly medially inclined and slightly upwards to get a screw across that. That was then altered slightly by nibbling away or drilling away part of the inferior aspect of the lamina so that you get the screw into a more direct approach, and then a translaminar approach, which is this one here where you literally just drill on the base of the lamina and then you're trying to get through what they describe as the true pedicle, getting through the lamina into the lateral mass and across. So it gives you a longer screw. So this one, in theory, avoids C2 problems, but is closer to the vertebral artery here. This one, in theory, avoids vertebral artery problems, but is closer to the C2 nerve root. So there's pros and cons of each. But certainly these fixation techniques directly into C1 have been the big change in instrumenting around C1 and C2, along with a combination of all those C2 fixation points I just showed you. So how I get, my preference is this one, so I still do this technique. I tend not to sacrifice the C2 root personally, and I just pack away. So I dissect down onto this area, it starts to bleed, I pack away, dissect the other area, pack away, come back to this. And if you go back and forth, you don't lose too much time by doing that. But I accept by taking the C2 root, you can probably be a little bit more vigorous with the bipolar diathermy and reduce bleeding if you need to. There are other novel methods to try and deal with C1 and C2. So this is a anterior plating of C1 done through a transoral approach, and that's been done a few times specifically for a Jefferson or burst fracture. And then these are some butterfly plates, and there's all sorts of other plates which are put onto C1 and C2 to fuse the two anteriorly, again through a transoral approach. Again, I have limited experience with these techniques, but people have described them in the literature. So I just wanted to illustrate a couple of cases just to show what can be done by limiting yourself with C1, C2. And I know there's a plethora of things out there that you can fix with C1, C2 with, but these are just a few. So C1 burst fracture. So there's very few of the C1 burst fracture that we fix anymore, but something which has a transverse ligament avulsion fracture with a significant spread, which sometimes would, because it can cause atlantar dens instability and cranial settling and sometimes neurology. So on a couple of occasions, I have done direct fixation. So this is true motion sparing. So what you do is fix the fracture is what you're trying to do. So you can put 2 lateral mass screws in and then a rod which you compress. It's nothing I've made up myself. So it's been described before and from the Ganga Hospital, and other people have described it. I think that the issues here, the tricky bits here, is getting these lateral mass screws in. So I think if you're doing this, navigation is quite important with intraoperative imaging as well. So then because the direction of your lateral mass screws sometimes is far off from where you'd expect it to be. And again, if you've used traction intraoperatively to try and reduce the fracture, then you need to have intraoperative imaging to guide yourself where you're going. But once you get the screws in, which is the trickiest part, and often particularly one side will be quite mobile, once you get it in, you can then use your screws to manipulate the fracture into position and then fix on one side and compress across the rod. And that gives you some direct osteosynthesis, which sometimes helps not having to fuse the spine. And patients do get good results afterwards, even if you haven't got a completely anatomical reduction. So I think that works quite well. The other fracture scenario is C2 fractures. So obviously C2 fractures are fairly common. Again, in the UK in particular, we don't fix many of them anymore, but when we do need to fix them, it's usually when they're compromising the canal. And this anterior osteosynthesis is an option in that sort of situation. So here you need to have the prerequisite that the fracture can be reduced, in particular reduced and stay reduced when you extend the spine, because your approach is going to be anterior and you need the neck extended to an extent, or at least the chin away from the neck. And it needs to be a fairly transversely fracture. So not having a very oblique fracture means you won't get a good perpendicular screw, and then that can fail. So the approach here is quite low. So you do a transverse approach fairly low at C5, C6, and then you're putting in a range of tubes and things to get yourself up to the base of C2, C3, and to fire your screw across. And it works quite well. So you can usually, I can usually only manage a single screw. People describe dual screws up there. And it does work well when you can get it reduced and when that reduction remains reduced. But I have had problems with this. I've had problems with this because often you can't get the fracture reduced with in extension. They often need flexion to reduce. And sometimes I've had non-union and screw backouts and pull-outs. So I'll be honest with you, for me, when you've got a significant fracture, which you can only reduce by flexing them, or in any case, probably my default now is to go to posterior fixation. So I think that C1, C2 screw gives you excellent fixation, excellent hold, good ability to manipulate. You can decompress the cord if you want to, and you get a good fixation which lasts. And again, not just my thoughts. So there's been some meta-analyses which again confirm that the outcomes, particularly in terms of implant failure and in terms of fusion rates, are much more superior if you do the posterior C1, C2 fixation compared to anterior osteosynthesis. Other scenarios that I use this, so inflammatory arthropathy, this is a patient with rheumatoid arthritis, and you can see the atlantar dens interval significantly increases, and that is a significant reduction of the PADI, or the posterior atlantar dens interval, to 10 millimeters, and the patient already had symptoms of some neurological issues. The key for me in this sort of a situation is, again, to get a CT. So I think in some of the inflammatory arthropathies, you can get a lot of erosive changes, and you need to be aware of that beforehand. And in this particular patient, it's all very straightforward, and we did a C1, C2 fixation, and it worked well, and you can see no change in the flexion extension here. And I think, again, standard for most rheumatoid practices now is to use the C1, C2 limited fixation. The only time we tend to veer away from that is if there's cranial settling. So in this patient with cranial settling, again, a lot of erosive changes, we sometimes get into a bit of trouble. So again, this is another reason I use CT, and you can see here CT angiography, which I'll come back to in a bit. But you often get very thinned out C2. You often get very small C1 lateral masses, and so the distance between C1 and C0 can be quite reduced, especially with the cranial settling. And so that makes it a little bit harder sometimes to get a C1, C2 screw in easily. And occasionally I then just default and go to the occipital cervical, do an occipital cervical fusion. And you can see in this particular patient, because that C2 was thin on one side with close to the VA, I did a translaminar screw, which worked well. But having said that, again, novel techniques. So again, described in India by Atul Goel. So this is using the C1, C2 spacer. And when you don't have a severe cranial settling, it's an option. So you do a posterior fixation, decompress the cord. Here you do need to sacrifice the C2 root, identify the C1, C2 joint clearly, and you can put an artificial space in. The idea is by pushing C1 and C2 away from each other, you can improve some of the cranial settling. So I've used it once or twice only. I don't have a vast experience in this. I have to be honest with you, my default, if the fixation was going to be feeble, would be go to occipital cervical. And on one case when I did this, the spacers did displace. And so that's one of the reasons I'm a little bit wary about using this. But it's an option. It's an option in some situations. So what are the problems with these sort of techniques? I think there's always the general technique of any operation, so implant failure, interventions, etc. I think some of these can be technically challenging early on, so you do need to be taught how to do this, go through these things with a mentor, do the appropriate cadaveric approaches. And but once you're familiar and you've got a bit of an idea of the anatomy, actually most of these can be done fairly easily. And again, it's workhorse now. You know, this C1, C2 fixation is done widely throughout the world, and actually the complication rates from it are pretty low. It was interesting that non-union is actually something which is still cited in the literature, but when you switch that back to non-union with other subaxial and supraaxial techniques, it's not too bad. So with one systematic review that I've shown you there, it's a 4.2% non-union rate, which means if you flip that, a 96% fusion rate, which is pretty good in my view. So I think non-union is not a major problem using the C1, C2 techniques. Failure fixation. So I think that is more likely to happen with a direct anterior C2 screw. I have not yet, and I'm sure it can happen one day, but I've not yet had a C1, C2 direct fixation fail on me or any of the other C2 anchors that I've shown you failed on me yet, except for the anterior osteosynthesis. Medial breach can happen. You're working around the spine. Actually, in that part of the spine, the medial breach is forgiving because the canal is fairly expansive. So it's unlikely you're going to get a neurological injury. And again, this is supported in the literature. And some argue that with the translaminar screw, you're less likely to get a medial breach because the approach is less medializing than the direct lateral mass or goal approach. I just need a comment on the C2 nerve root. So C2 nerve root is described as being sacrificed, and it's supposed to make it easier to get the C1, C2 joint, reduce blood loss, and allow the fusion into the C1, C2 joint. And it doesn't really cause much harm because many people have a bit of anesthesia on the occiput and they deal with that. But just a slight word of caution. So despite this, people do describe, I mean, there's some literature describe up to a 40% occipitalgia rate because of C2 root resection. Now, I don't think other, there's not many papers out there suggesting that, but most people settle to about a 6% occipitalgia rate. And that's actually whether you do sacrifice the root or not. So you do need to be aware of that. And the risk is that if you do not resect the root appropriately, that you may get occipitalgia. And there's been a couple of case reports of occipital pressure sores. So you get complete numbness, the patient's still bedbound for whatever reason, and then they get occipital sores, which has been in theory because of the occipital anesthesia. So just be aware of that as a potential downside of sacrificing the C2 nerve root. And then there's other things that can go wrong. So I think when you start looking at what can go wrong, it does get a bit surprising and a bit anxiety provoking. So in this cross section, this is C1 here. And what has been described in the literature is C1 screws being pushed into the internal carotid artery, which sits just here, and or hypoglossal nerve injury. So that's also been described, both of them. And really that would happen if you have a long screw, which is truly bicortical, so more bicortical than it needs to be, but also a laterally directed screw. And I think if you look back at all of these initial pioneers, that all of them have asked us to direct the screw medially. And I think this is one of the reasons. So when you're doing your lateral mass screw, whichever approach you're using into C1, then try and just make sure that you do some degree of medial inclination to stay away from the ICA and the hypoglossal nerve, because they don't always sit as far as this. They can be a little bit closer to the lateral mass. If you're doing that direct C1, C2 transarticular screw anteriorly that I showed you earlier, then again, because that does go up and out laterally, then that can hit the ICA. So again, you've got to be careful about that. So that's the screw which comes up from here and up and out. So do be thoughtful about that if you are doing it. The more likely artery to be injured is the vertebral artery. And again, the rates have varied. So probably most people feel there's about a 4 to 6% risk of vertebral artery injury. And it's usually the V2 segment of V3 segment of the vertebral artery, which gets injured. So just be aware of that. I think a CT angiogram for me when I'm doing C1, C2 fixation is pretty mandatory. So I use it every time. You can get lots of surprises. So this is a particular arcuate foramen vertebral artery. So the vertebral artery sits in a little bony tunnel before it disappears. And this can be paper thin. So if you're sitting here thinking you're dissecting away on bone when you're planning to do a translaminar approach, then you could end up finding yourself drilling into the vertebral artery or dissecting onto the vertebral artery. So it's worth knowing this ahead of time. And in this situation, as long as you know it ahead of time, you can go ahead and just do a direct lateral mass screw rather than going through the translaminar approach. There are lots of other vertebral artery variations that can catch you. So, I mean, if you look at this one, I mean, this would scare you, wouldn't it? So this is an arterial branch coming off and going across the lateral mass. So again, here, then you would switch and do the translaminar approach. So just having this information beforehand is really quite important. So I think having a CT angio before your opera is I would say mandatory to stop you getting into trouble. Other enabling technologies, so navigation with intraoperative CT or intraoperative 3D spin, I think is quite important. I don't have access to this all the time, so I do use navigation now when I'm doing C1, C2, where for the many years that I started, I didn't used to use it, but it is helpful now when I can use it. I think the benefit of having intraoperative imaging coupled with your navigation is that if you do make a change to the patient position, if you do any reduction, then you can intraoperative imaging will pick that up, and then you get more accuracy. So I think this is a part of the spine where navigation is without a doubt helpful. And for me, in terms of trying to avoid risks and stopping yourself getting into trouble in the future, I do think that the tech companies are coming up with more and more. So what I'm really looking forward to is augmented reality. So Magic Leap is an augmented reality facility that Brain Lab are trying to come up with, hopefully in the next year or so. And what that does is put the preoperative CT angio onto your 3D CT image. And in theory, you can put goggles on and you can actually see that preoperative angio on the patient. So then that gives you a bit more of a guide in where you're going to be directing your screws and trying to guide them away from artery and nerve and other things. So I think this is going to be an important next step if we are going to be getting safer and safer with these techniques. So in summary, there's a range of screw fixations and techniques available. I think it is important that we recognize that we can limit our fixations to just C1, C2 in a wide range of disorders. It is important to know your anatomy and to make sure your screw direction fits with what is being taught, and particularly that medially inclined C1 screw, for example. The familiarity with the technique has reduced these risks over time, and I think you do need to think about preoperative workup such as CT angiogram and think about navigation if you have it. I'm not saying navigation is mandatory by any means. I think we've all done it freehand and it's doable without any problem at all, but it just helps. It's just another step to make things safer. Thank you.
Thank you, Mr. Vijay Jasani. That was an excellent overview of the entire instrumentation around C1, C2. Any of the speakers, would you like to ask any questions, please? We'll take a few questions. Well, I would start off with one question. Well, two questions, both related. You did mention that you would do a CT angiogram and as a routine. Is that you would do that routinely for an congenital or traumatic or any case, or would you selectively use in these cases? You definitely would want to use an CT angio.
Good. Yeah, thanks for that. So I think the congenitals are definite because you can get vascular variants with the congenital issues. But my practice now is in every case. So we're lucky enough I can get a CT angio on a trauma the same night the trauma comes in, so I can get on and do that. And so I do every time I'm planning a C1, C2 fixation, I do a CT angio.
And if you see an high riding, and if you see a high riding vertebral artery, even in your preoperative planning, would you think about a transarticular fixation, a translaminar straight away? And would you do it unilateral or bilateral depending on the dominant side, or how do you plan that?
So yes, all good questions, absolutely. So yeah, so it depends on what the high riding is. So some of the high riding vert still has enough of an isthmus or a true pedicle screw, which would then take you away from the vert. So because this was an overview, I didn't go into the detail of C2 screw itself, but the C2 screw, if you do the true pedicle, tends to be safer for the vert than if you're doing the isthmus screw, because the isthmus screw is heading towards the vert and therefore the high rider, whereas the pedicle screw tends to get you away from that. So if you look at that, and the pedicle screw seems to be safer, and you can still put a pedicle screw in, and it's reasonable, and it gives you good fixation, which is why we still try and do that sort of a screw, don't we? But so it does depend on what type of high rider you have. But yes, if you have to do a translaminar, I have no issues with it at all. And doing a double translaminar, I've done before, and the actual fixation is fantastic. The problem is connecting it with the rest of your screws. That's the only problem. So then you use the offset connectors, etc., and that works quite nicely. But yeah, I think if there's a non-dominant vert and there's a reasonable bony tunnel, then I would probably have a go with an isthmus or a pedicle screw. I think I don't know why we all tend to just like to put the screw down that level there rather than translam. But if it's a dominant vert, then I would stay away from it. Definitely, I would just use a translam. In the case I showed you, the one I did occipital cervical, I would just do a translam screw on that side, and it was a dominant vert, which is why I did that.
Right. Thank you. I think Rajat has a question. Please go ahead.
I've got a comment and then a question as well, Vinay. Your presentation just reinforces my view as to why I don't do this, because I don't do enough of this. So one of the questions, well, both are interrelated. Should it be done by volume? If you've got a surgeon who does a lot of it, should we be kind of encouraging them to do it? And because there are not that many of these C1, C2s fixations that you would do in a year, at least in the UK. The second kind of leading on to that is that I know you said CT angio is mandatory. I don't know our colleagues in India, do they do it in every case? And is now in the current climate, is navigation mandatory now?
Okay. So you know my views on navigation. Let's start with that first. I think navigation is a reasonable adjunct. I do not think navigation is mandatory for any part of this surgery. So we all have done, and all of these techniques were pioneered without navigation. So I completely accept that we can do these techniques without navigation and do them very safely. And again, having the surgical skill that we have and the knowledge of anatomy and learning and changing all the time. I do believe that in some parts of the spine, and C1, C2 is one of them, then again, having navigation gives you that edge. So it gives you a little bit of confidence on your direction. It doesn't take over. It's not a live picture. We must always remember it's not a live picture, but it does help. And especially when you've got, if we can start to superimpose vertebral angiograms and stuff like that onto our navigation, and that's a bit of a game changer, and I'm more attracted. But I certainly wouldn't say that's mandatory. In terms of CT angio being mandatory, I don't say that either. I think it's important. I think in congenital it's mandatory because your variants are huge. But when you've done CT angios a number of times, you will pick up that there are some scary variations which rapidly make you become mandatory to do that. So it'd be really interesting to see what Dr. Bala feels, if he feels that he would do them all the time. So it'd be good to get his view on that. And then your first question, pooling on these things, I don't know. I think again in a unit, if you have somebody who does a lot and then you want to learn and do that, it's important to have succession planning, and I think working together makes a huge difference. If in a region you want to pool cases, that's fine. But remember, some of these things are trauma cases in the UK in particular, and that it's probably better that we have all of this information and skill sort of dispersed appropriately across the area, rather than saying, oh, well, only one group of people should be doing it. That's my view anyway. So I don't know what Dr. Bala feels about some of this.
Sure. I mean, a couple of things. One is navigation, as you said, is being now very common in India as well, at least in the private sector and in the bigger institutions. And it does help, especially with the congenitals and others. But if you look at, broadly speaking, 80 to 90% of surgeons don't have access to this. And in India, we do a high volume of CV junction, C1, C2. And I think the results are variable, but definitely it's an adjunct if you have access to it. Regarding CT angiogram for congenitals and trauma, I would definitely do. I mean, I work in a private sector. I have access I could do for every patient, but I don't do it routinely. We had a recent discussion in one of our meetings in India, in one of the sessions. And for people like Dr. Goel, he never does an CT angiogram, but he's exceptional. But majority of people do not do a CT angiogram as routine. And they just, I guess, deal with the problem as and when it comes. And probably it's partly because of the access to CT angiogram, widely in the government and in the smaller setups in India. But I guess, most of us do a CT, and some people even don't do a complete CT scan. They operate with an MRI and X-ray. So, but if you have a CT, I think adding on an angiogram sequence makes sense. That's my view. I think we'll move on to the next speaker. Next is, I would like to introduce Dr. Kaushik Ghosh. It's a rare privilege for me to say that, when he was a senior registrar at that time, the Royal Preston Hospital, I was a junior registrar. He had come in a lot of experience from India, and I learned so much from him. So I'm really pleased to see him after a long time. He's an amazing surgeon, a good teacher. His presentations, I used to love the way he presents, and I'm looking forward to his talk today. So Dr. Kaushik Ghosh, he's currently a senior consultant at the Lancaster University Hospital in Preston. Please share your screen.
Is that visible?
It's visible and we can hear you. Thank you.
Thank you very much, Bala. I think, you have told too much, but I always like teaching. So very good afternoon to everyone. And of course, good evening to all my Indian colleagues. And thank you very much, Bala, and your team to organize this session, joint one. And thanks for inviting me as well. So as you said, I am a neurosurgeon by background, but I have a special interest in complex spine and oncology. I'm also incidentally the national lead for British Spine Registry. So this is where I work for our Indian colleagues, Preston Hospital, which is in the northwest of England in Lancashire. So we really see sun here. No conflict of interest to declare for this talk. So pathologies affecting the cervicothoracic junctional area is not any different to the rest of the spine. We have come down, we learned a lot from the talk of Vinay and Lennel about the upper part. So now we'll concentrate in the cervicothoracic. So it does affect very similarly trauma, tumor, infection, degenerative. And the trauma does affect slightly differently because of the biomechanics in this junctional area, and it's about 2 to 9%. Most of the literature says around 10% of all cervical trauma affects in this area. And the key point is sometimes trauma in this area used to be missed because of the difficulty in imaging. Now, routinely after ATLS doing CT scan, that incidence has come down. So what is the specialty of this cervicothoracic junctional area? So it is different. It's considerably different in terms of the biomechanics, anatomy, and access and X-ray during operation compared to the rest of the spine. So what about biomechanics? It's a junctional area of a considerably mobile cervical spine and very rigid thoracic spine. As also you can see, and we all know, it's diametrically opposite curvature. So a lordosis in the cervical spine joining with the kyphotic area. So that puts very high stress in the junctional area at C7T1. So that makes it quite unique. In terms of anatomy again, there is a change from upper cervical spine gradually to lower cervical spine and C7 in terms of lateral mass, pedicle, and angulation of the spine, all of which need to be kept in mind when stabilizing this area. Now, C7 has a broader lamina and larger pedicles where the lateral mass has gone smaller. And that continues in the thoracic spine where the pedicle is much bigger, but there is no concept of lateral mass as such there. In terms of access, generally anterior and posterior cervical spine is quite easy to access, and it's not a major problem. And if we are lucky, we can go anteriorly all the way up to T1 in selected cases. But further down in upper thoracic spine, anterior access is not easy. And if it is necessary, you might have to go for manubriotomy, sternotomy. And this image, I'm not going into the details, but just a glimpse of this, I suppose, is giving the picture how difficult it is going through those big blood vessels and the heart to access the anterior thoracic spine. Now, what I find is the critical thing is decision making in this area about the length of construct and what type of construct it should be. Either it should be anterior or posterior, or it should be fused 360 degree. And then, of course, the selection of the modality of fixation. So based on that knowledge, I have divided the whole pathology in this area into two groups. I mean, I haven't seen anywhere this division, but I thought this is a good idea to discuss these two groups separately. One of the groups of pathologies which actually cross the C71 junction, and the other group is pathologies around the C71 junction, but not crossing that area. So from upper part, it stops at C7, or any pathology in the upper thoracic spine stopping at T1. And there are differences because of the biomechanics and what evidence we have. So I'll start with pathologies which stopped at C71 junction, at cervicothoracic junction, and not crossing across. And this could be, as I said, both pathology higher up or lower down, but not crossing this area. Now, the key point in this is whether we have to stabilize across the cervicothoracic junction when the actual pathology is not crossing the cervicothoracic junction. And does it need just anterior or posterior or 360 degree? So these are the key things in those instances. So I'll go through few of example cases from my practice, and I will rather concentrate more on the controversies of the decision making, because Vinay and Lennel has quite extensively gone through the surgical side, its complications, etc. So I'll more concentrate on the decision making. So on the left side here, straightforward 2-level anterior cervical discectomy and fusion, which has stopped at C7. And on the right side, you can see a case of vertebrectomy with cage and plate screw because of C6 pathology, but the fusion has extended to C7. And in both those cases, the fusion or the construct has stopped at the C71 junction. So is it reasonable? But I think most of us will say that in situation like this, it's quite reasonable, and you don't really need to go across the more mobile C71 junction. Next is a 55-year-old lady, had a full flight of stairs, and presented to me with wobbly gait, difficulty in walking, and on examination, she had early myelopathic signs. And these are the images. So in CT, you can clearly see there is a facet movement, almost came out at C6-7, and the spinous process has opened up. So clearly unstable at C6-7. And you can see the disc is affected, as well as the posterior ligaments were affected as well. So the question again comes, can we limit the construct at just C6-7, or we have to go across the C71? So I left it just a localized fusion in this case, and did a ACDF with plating as well as C6-7 posterior stabilization. And I got away with it. This is post-op 4 months, but I have followed up another couple of years, and there was a good fusion without any major problem. Now coming to the other side, say another gentleman, 52-year-old male, fell down in the garden just from standing position under the influence of alcohol and presented with neck pain. But he didn't have any features of neurological deficit, but he was known to have ankylosing spondylitis. And that's his scan. So he is clearly unstable at C6-7, but in this case, I suppose all of us will accept, because of his background pathology and the type of the fracture, it will not be safe to do just C6-7. And we have to go across the cervicothoracic junction. And that's what I did in this case. And in fact, I did a 360 degree as well. Coming to the other side of the junction, or before that, a controversial case, interesting case of infection in a 71-year-old who had this infection, osteomyelitis of completely C6 and most of it C7. And he was developing neurology. So with antibiotic, it was not responding. So did a complete vertebrectomy of 6 and 7 with an expandable cage plate and screw. But I haven't done anything posteriorly, haven't gone beyond the C71 junction. Was it right? Was it enough? I don't know is the answer, but this is a post-op follow-up almost a year down the line, and he did well with that fusion. Now moving to the other side of the junction, this is a gentleman who presented with myeloma of T2 vertebral body collapse and compressing the cord. So did a decompression at T2 and fixed T1 to T3. Is it enough? Do we have to go beyond, higher up? Very similarly, an example of fracture. This is a 56-year-old gentleman who was working in the roof, fell down, and had a 3-column fracture of T3. So I did a fixation T1 to T5 and put a cross connector, and obviously not gone beyond C71 junction. So what is the evidence? Do we have enough evidence? Now, I've gone through few papers. There are quite a number of papers. This was published in Journal of Neurosurgery Spine, and they have looked at the effect of instrumentation at C71 junction on a long segment instrumentation. So this was basically a cadaver study, and they have studied on 8 cadaver and looked at the range of motion at C7 and T1. And they compared fixing T1 to T6 versus C6 to T6 fixation. And quite interestingly, they haven't found any difference at C7 T1 range of motion in either of those groups. So either it is fixed T1 to T6 or fixed C6 to T6, unless there was disruption of supraspinous and interspinous ligament. And they have also then done facet capsule disruption at T1, which also did not make much difference in the movement at C7 T1. Another study, which was published more recently in the print version in 23 in Journal of Neurosurgery Spine, and they were looking very similar, but other way around. So this is another cadaver study in a fresh frozen cadaver, and they measured the range of motion and intradiscal pressure of distal adjacent level, and they have put it in 3 groups, C3 to C7 construct, and compared with C3 to T1 and C3 to T2 construct. And what they found is the range of motion is significantly high when there is only C3 to C7 construct, and it hasn't gone beyond the junction of C7 T1, as well as the distal disc pressure in the distal beyond the construct was very high when there was a construct only C3 to C7. But how does it reflect in the actual clinical scenario? So I've gone through a couple of clinical studies. This is published in 2021, again in Journal of Neurosurgery Spine, and they have looked at 875 patients. So it has a good power, although it was a retrospective analysis from the spine registry. And they have compared all the patients where the fusion stopped at C7, 470 patients, and where the fusion gone beyond cervicothoracic junction, so 405 patients. And they found total 17 non-operative non-union in those cases, and their follow-up was quite long. Quite interestingly, again, there was no difference in the 2 groups about non-union between these 2 groups, whether you stop at C7 or go beyond. This study is very clearly asking a question whether it is safe to stop at C7 when we are doing a multi-level posterior cervical decompression and fusion. This was in Spine Journal. And multi-center study, although retrospective analysis, they divided into 2 groups very similar to the other one, fusion stopping at C6, C7 or going beyond into thoracic spine. And their finding shows actually in the group 2 where it went to thoracic spine, the operating time, the blood loss and length of hospital stay was quite high, as expected because the construct was much longer. But the rate of revision was not statistically or clinically different in the two groups. So they concluded it's quite safe to stop at C7. Moving on to the pathology across C7-T1 junction, I think it is less controversial because when the pathology itself is across the junctional area, in that case, your construct has to be beyond it anyway. But the main question in that scenario is, does it need stabilization in some pathologies? And how, if it does need stabilization, how long the construct should be? So again, a couple of examples from my practice. This is a lady, 67. She presented with progressively worsening myelopathy, and there was an intradural spinal meningioma. And unfortunately, I had to do C7 and T1 laminectomy, which is just across the cervicothoracic junction. So does it need fixation in these cases? I didn't, and I got away. She had a 3 years follow-up and so far hasn't got deformity. But these are the controversy. Very similar situation, intramedullary tumor, intramedullary ependymoma, and needed operation, and I had to do C7-T1 laminectomy. Previously, we considered laminoplasty, but I'm not very sure how much it strengthens the spine once you have done laminectomy. So I just did laminectomy, excised the tumor, and you can see this is a 2-year follow-up already in the scans. The operation was done in 2016, and this is a 2018 scan. It hasn't actually gone worse. But in situation like this, it's totally different. This is a 42-year-old gentleman with a known history of drug abuse, came with osteomyelitis involving multiple bodies. And I don't think there's much controversy in this, that you have to go across and you have to stabilize. And that's what it was done. So implants in this cervicothoracic junction, I think Lennel and Vinay has gone through quite details about those. But we do have wide range of implants available: anteriorly expandable cage, plate screw, and some sort of other screws like transarticular screws. Posteriorly, for subaxial cervical spine, lateral mass screw, pedicle screw, laminar hook, which is not used very commonly, but sometimes I find it a good adjunct when we are not doing laminectomy. In C7, you have the option of lateral mass screw, pedicle screw, transfacet, and laminar screw. Thoracic spine, it's usually pedicle screw is the most favorable one. And we need to have transition rods because of the differential diameter sometimes used in cervical screws and thoracic screws. And if it is a long construct, sometimes you would need cross connector. Sometimes if it is very difficult to align the screws, then you might need a side-to-side connectors to connect the rod. But what I feel the main challenges in this area is the decision-making. Number one decision-making is whether it needs stabilization in situations, and when it needs stabilization, where to stop, how long the construct has to be. Does it need to go anteriorly or posteriorly or 360-degree fixation? And of course, you have to take into consideration the difficult access anteriorly in case of upper thoracic spine. Now, you have a wide choice of implants available these days, but I'm quite mindful about the difficulty in getting any, good quality imaging, intraoperative X-rays during operation in cases of lower cervical and upper thoracic spine. And sometimes you have to just rely on AP X-rays. I know a lot of you might do freehand pedicle screws, but in my practice, I rely on X-rays. Probably the neuronavigation and intraoperative CT or 3D spin will mitigate some of those problems, and that will help. But the key thing, I think, is the decision-making about the length of construct and how to fuse and what to fuse. Thank you very much.
Thank you very much, Kaushik. That was a very good description of the challenges in this very, very complex area. And it varies from patient to patient depending on what their neck length is, how short or long it is, and whether you can actually access anterior or posterior. We'll take a couple of questions before we go to the next speaker. Anybody has questions?
Perhaps I could start off,
Sure.
Bala, if that's okay.
Yeah.
Cervicothoracic is a difficult area because lots of different pathologies occur in that area, and it's not that uncommon. Trauma, infection, tumors, as you covered. Do you have a view of using? So the difficulty I have faced when I've done this, especially in patients who are got a large kyphosis, is to contour this graduated rod that goes from 4 millimeter to 5.5 millimeter or 6 millimeter that used to be there, the old AO synapse rods. Do you have any view on using the long lateral mass screws continuously as a pedicle screw down into the thoracic spine so that you don't have to mess around too much with the rod?
So you mean use as lateral mass screw, but use the pedicle screw? Is that what you were saying?
Use the lateral mass screw as a pedicle screw. So use the long lateral mass screw in the pedicle. So then you have a single diameter rod going across as a tension band.
Yeah, I mean, there is a shift. I was attending one course. There's a shift that more people are doing pedicle screws, especially with neuronavigations, even in upper cervical spine. I personally still rely mostly on the lateral mass screw, but I agree pedicle screw is probably much stronger as well. But in terms of alignment, I think lateral mass screw usually doesn't go too much off when you're comparing to upper thoracic spine.
I'm sorry, Kaushik, I don't think I made myself clear. This probably is no. Use the lateral mass screws as lateral mass screws, but then when you go across the thoracic spine, then you go into the pedicle screw area in the thoracic spine. Then you have to use a graduated rod. Yes.
Yeah.
So I find contouring the graduated rod difficult at times. I don't know if other people have had a similar issue. And sometimes now I've used just the 4.5 millimeter rod straight across and use the lateral mass screws that are available in the thoracic spine as pedicle. That's right.
Yeah.
To avoid using the graduated rod because
contouring.
Contouring. Yeah, I get sometimes some patients have got a very deep thoracic kyphosis and they've got a large extension of the cervical spine.
Yeah, it's very much possible. And some of the companies now actually coming up with very similar rod without this junctional change. So even if you put lateral mass screw and pedicle screw in upper thoracic spine, you can use that without transition rods.
Yeah, if I could just make a comment on that. I think biomechanically, I think I would not use a lateral mass screw as a pedicle screw because it's 4.5, unless you're just at T1 and T2 alone. Because even there, you could put in a bigger size screw. So I think because the junction takes so much stress, and plus we're dealing with some pathology, which is usually anterior. So and if you're not going to go a 360 degree, then I would not use a lateral mass screw in the upper thoracic spine. Contouring is difficult. And as Kaushik said, a lot of companies now are coming with a single screw, so which you can use across without having the tapered screw, which you have to cut separately and then contour it. So this is my view. And I've also seen this presented a few times. People trying to do pedicle screws or other screws in order to avoid the junction, and you either have to skip C7 or T1 because you can't have both of them and also have the tapered rods because you cannot get it. The screws will be very close together and you either have to skip one of them. So I think Dr. Shashin Ahuja has probably something to say about that. He's raised his hand.
No, I agree. It's sometimes, as you rightly say, you can't get 7 and T1. at the same time. That, I think, goes without saying, unless you are very adept. But yeah, I'd go back to Rajat's point. Yes, you could use the 4 mm rod all the way down, but I think with what Vinay was explaining about the weight of the head, the biomechanics, and the quality of the bone, different pathologies, you've got to be mindful of all that. But if you have supplementation from the front and a reasonable fix from the front, and if you're using that as a posterior tension band, that I think is perfectly acceptable. And on occasions, it's a pain sometimes to contour the tapered rod. I've gone tapered rod on one side and I put a rod and a domino on the other side to connect with a tandem connector. It depends how things line up and how things are. So you mix and match whatever is easy at the time. Remember, it's towards the end of the game that you are doing all this, and you're going to get out of there comfortably and
Yeah.
safely.
It usually comes in the evening. That's the
Correct.
tragic part. So
Correct.
in my practice, what I do, Bala, is majority of the time I skip C7 because you are doing long construct and no fighting between the screw heads. So a lot of time I skip C7 because C7 could be a bit tricky also. You are neither here for lateral mass, not there for pedicle screw. It's not big enough pedicle and not big enough lateral mass screw. So in those situations, I just skip. One big advantage of C7, you can even put other things like laminar screws, and there is no vertebral artery there. So it's much safer in that sense. But rest, I agree. I still tend to use the pedicle screw for pedicles and lateral mass screw for lateral mass.
Okay, thank you. Bala, shall we move on?
Yes, please, we can move on. I think Gautam Zaveri is held up with an emergency, so he's not going to be joining. So we can have the next speaker, Professor.
So it gives me great pleasure to introduce Professor Sachin Ahuja, again, a close friend and a senior spine surgeon. He's been a consultant spine surgeon in Cardiff and Wales since 2003. He has got the chair of orthopedics. He is very actively involved in training. He's the current UK SSB, which is the United Kingdom Spinal Society's board chair. He's very active in AO Spine and does a lot of expert advice to NICE and MHRA, NHS England. And I'm very grateful for his time so that he can spend his experience with us on the lumbo-pelvic fixation. Session, over to you.
Rajat, thank you. And I would like to say thank you to BAS and ASSI to invite me to speak. Both societies I'm very close to, as I trained in Bombay. I have very close links with Bombay and spine surgeons in India. So good afternoon, good evening, whatever time of the day it is. Hope you're having a nice day. So I'll just, like Rajat asked me to speak and said, we're going to talk about junctional issues, and said, can you talk about lumbopelvic stabilization? So I thought, okay, I'll take this opportunity to talk a little about it, talk how I see it, and share some experiences about a very complex problem. Like you can see, we've talked about occipito-cervical, C1, C2, cervico-thoracic, and all these junctions are critical and difficult to handle and manage. So again, thanks to ASSI and BAS for the invite. Got no disclosures. So as you can see, all through, we've got to look at the spinal balance, the spinal alignment at every junction that we're working on. No more so in the lumbosacral region, which is quite a challenge if you're dealing with an adult spinal deformity, or even a child with neuromuscular scoliosis, where it is not uncommon to go past the lumbosacral junction. But perhaps the lumbosacral junction is more forgiving in a child compared to in an adult, where you got a significantly degenerate spine, whereas in a child spine, the spine is still a little bit flexible. It gives you that degree of freedom, so it does not cause significant problems, although it can. So I'm not saying it doesn't. So the major issues are the long lever arms, long lever arms at every junction, the head and the neck and the thoracic, thoracic and lumbar and sacral, and what the kinematics and kinetics are of that area, the amount of movement that each junction has. So a lumbar spine, which is very mobile, to a fixed sacrum, and the forces that act on the lumbar spine and the sacrum and the pelvis, and the interplay, which we need to understand. We need to understand the biology, the quality of the bone, the quality of tissues you're dealing with, and more importantly, the overall spinal alignment, which we have to work through and encounter. So the rest of my talk is just this, all these slides with all these measurements. No, I'm not, I'm just joking. But as you know, these are the parameters that we take into account for spinal alignment, the balance, how the spine lines up. And there are critical ones that we work with. And the common ones that we work with are the pelvic incidence, the pelvic tilt, and the sacral slope, which have a bearing on how we recreate the lumbar lordosis and how we align the rest of the spine onto the pelvis, which is a critical aspect of correction for adult spinal deformity, where vast majority of lumbar pelvic stabilizations are performed. So the main indications for arthrodesis to the sacrum are for spinal deformity, as I explained, both in children and adult, which involve the lumbosacral junction, and it gets more involved in the adult practice rather than the pediatric practice from my point of view. We don't tend to cross the lumbosacral junction much in neuromuscular scoliosis. We perhaps are of the Nottingham school of thought, where stopping at L5 usually suffices, whereas I know there is a distinct different school of thought that we have to cross the lumbosacral junction in neuromuscular kids, but we keep it for specific cases, not all. And that would fit with the next point, where if there is advanced degeneration in the L5S1 motion segment, then you have to cross the lumbosacral junction. And young children, usually that segment is pretty good and it is quite forgiving, and it allows a degree of movement between the spine and the pelvis, especially for kids who have got some control so that they can move forwards and backwards, especially kids with Duchenne's. I know they get muscular issues, but it does allow them to lean forward. So that is one of the reasons why we tend not to go to the pelvis if we can avoid it. Also, if there is instability at the lumbosacral junction because of degeneration or previous decompression, then you have to cross the lumbosacral junction. And any absence of these factors, you can stop at L5, as we've just discussed briefly. So you can fix into the pelvis or the iliac wing, and it's shown that there is still a degree of, and the problem we have is the non-union rate at this junction. As we explained, the kinetics and the kinematics of the movement and the forces across the lumbosacral junction. So you can fix into the iliac wing and improve the lumbosacral fixation, and it helps in preventing sacral fractures, but it can cause issues as well. So I'll come to all those points in a minute. So what is the evidence, right? So the evidence is quite varied. Unfortunately, when we start looking at good evidence for any of these strategies, we have to be very mindful of what is available, what isn't. So what are the options for lumbopelvic stabilization? The options would be, like we just discussed about the cervicothoracic region, where you can have a 360 stabilization with an anterior fixation and a posterior fixation. And there are different ways to deal with that. What are the options for pelvic fixation, right? And there are different strategies that one could use. And the other important one, which is getting used more and more, is whether we supplement just the two-rod construct with a multi-rod construct. So I'll go through a few of these options. So for 360 stabilization, like we discussed for the cervical thoracic junction, that you could put a cage from the front, same way you could do an anterior lumbar interbody fusion. At L5S1, I have read papers in the literature we talk about lateral lumbar interbody fusion cages. I find it difficult to access L5S1 from the lateral side. L45, potentially you could, but L5S1 would be tricky. So in L5S1, we tend to rely on an anterior lumbar interbody fusion. You could achieve the stabilization from a posterior approach, doing a PLIF or a TLIF, although there are some papers in the literature we talk about lateral access as well. So what this is doing biomechanically is supplementing, giving us a 360 global fixation at the lumbosacral junction, which biomechanically would be strong. I don't think anybody would argue against that, as long as we've not denuded the end plates and as long as we've not been silly with the way we have addressed the anatomy and achieved the fixation, which gives us a good global biomechanical fix. And I think in the biomechanical literature, there is ample evidence to support that. Whereas in the medical literature, talking about clinical cases, there isn't any hard evidence to say an ALIF is better than posterior TLIF or PLIF or lateral access. But of course, an anterior approach with the biomechanical aspects, you can see you get a bigger footprint of a cage, you get better clearance of the disc, and a better fixation of the interdiscal space and a fixation in the interbody space. And that's something that we tend to rely on. And I know some people may dispute that and say we could do a good PLIF and give you as good a result with an ALIF, but the jury's out there and the evidence is very varied and there is no strong evidence for one or the other. From the iliac fixation point of view, there are two main options available. And after you're stopping at the S1, you can implant screws into the ilium. So you could have an iliac screw or iliac bolt, but there are risks with that. And again, because of that long lever arm with that movement, what it's going to do, it's going to keep causing repeated trying to pull on that iliac bolt, which causes loosening. And there's a high failure rate for that. And it can cause pain. And don't forget, if it has not been implanted appropriately and buried reasonably well under the iliac wing, under the PSIS, it could be prominent and can cause pressure areas, etc. So instead, a lot of people rely on the S2 ALA screws, which start at the junction of the, at level of S2, and it traverses across the, to the ala and through the sacroiliac joint into the ilium, which allows you a reasonably big size screw, which can go across into the pelvis, which gives you better fixation. And there is enough evidence to say biomechanically that the S2 AI screws have got a better hold and a better fixation compared to the iliac screws. And they're relatively easier to perform. And because of the biomechanical aspects I've discussed, they require less revision and they're less prominent compared to the iliac screws. And they're prone to fewer surgical site infections and wound dehiscence. And there is some evidence in the literature from a clinical point of view which suggests that the S2AR screws are slightly superior to the iliac screws or iliac bolts. Saying that, I just said one iliac bolt, you could put two iliac bolts. And it also gives you the option that you could have an iliac bolt and an S2 ALA screw, which you could start somewhere there. So you can mix and match. You don't have to be so compartmentalized that we just stick to an iliac screw or a S2 AI screw. If you want, based on the anatomy, based on the biology, based on the bone quality, you could have more fixation points into the pelvis. And the other advantage which this S2 AI screw provides is it gives you three cortexes to hold. It holds on the outer cortex of the sacrum. It holds into ala past the sacroiliac joint and into the ilium. So it gives you three cortices. And even in a relatively poor quality bone, it gives you a good hold. So it's something that we need to be aware of, something that we can utilize, and it works quite well. The other option I mentioned was the multi-rod construct. So we could, rather than just rely on a two-rod construct, we could rely on a multi-rod construct. And there is evidence to suggest, low evidence although, that multi-rod constructs are superior to two-rod constructs because it helps reduce motion, it reduces the strain on the rod, and it has greater resistance to rod fatigue. And again, all these parameters, all these references, there is a low clinical evidence for the same. But one of the things which comes through is, especially when you're doing a three-column osteotomy, like a pedicle subtraction osteotomy, etc. And there, the trend is that if you put multi-rod constructs, they tend to be superior to two-rod constructs. Although someone might say you could put different type of rods in. Rather than use titanium rods, use stiffer cobalt chrome rods. So as I explained, there are a lot of different strategies available, a lot of different techniques that you could utilize, and there are different ways to skin a cat, but try to understand all this and use these as and how you want, so that you can get the best possible outcome for the procedure you're performing to achieve a good lumbosacral stabilization. So I'll just go through a few examples, only success stories. No, not really. It's just go through a few cases that we've done at our center. So here you've got somebody who's got a coronal malalignment and a sagittal malalignment, presenting with back pain and stenotic symptoms. And in the situation like this, example L3-4, if you've got stenosis, you cannot just do an isolated decompression or an isolated decompression and stabilization, because that, unfortunately, from a coronal point of view, and maybe from a sagittal point of view, it may work, but from a coronal point of view, it would fail, as you can already see the rattle subluxation between L3 and L4. So in those sort of situations where you've tried all sorts of non-operative measures and tried to control the symptoms, and especially injections, etc., which give some relief to the patients, and the patient goes, why can't you do something to help me? Yes, we can, but it is something that has to be discussed, has to be, you have got to be very candid with the patients as to what is achievable, what is not achievable, and what the potential risks and harm that could be caused because of the surgery. I'm not talking about risks and harms of because of not doing this properly. It's just the repercussions of what we do, because whatever we do has repercussions without actually causing any harm to the patient directly because of inappropriate procedure. So here you can see on the lateral bend, it's quite a stiff curve. And this patient, all we had to do was a posterior realignment, a posterior multi-level releases, and realignment and fixation using iliac screws, which was quite successful and quite comfortable for the patient with a reasonable outcome, right? Yes, you can get issues after, like back pain and intermittent issues, but fortunately, this patient did not have any significant issues. And I keep saying that because if you read the literature, complication rates following idle spinal deformity are very high. So if somebody says, I've not had any complications in operating on these patients, they're not giving you the facts, unfortunately. Here is another one who's got a significant alignment issue, presents with back pain and leg pain. And not only do they have a significant malalignment on the coronal plane, but a significant malalignment on the sagittal plane as well. And you can see on the AP X-ray where it is quite badly malaligned, and the CT scan demonstrates that. And this, perhaps, you would find it very difficult to realign just posterior, and you may have to rely on some sort of anterior and posterior procedure. And in this situation, we resorted to a PSO, and again, fixation down to the pelvis, into the iliac crest, and with a reasonable alignment and reasonable spinal balance for the patient, as you can see on the X-rays. This is another lady who had a discectomy performed in a hospital not far from us. And she unfortunately developed postoperative infection and spondylodiscitis, and had neurological issues again with significant weakness in her legs. So she was referred across to our center, and you can see she's got significant imbalance in the spine, both in the sagittal and the coronal plane. You can see the infection that she's got in the disc at L4-5, which is quite significant. And she was treated with antibiotics initially, but she was having significant neural problems and mechanical problems, both. This is a CT, and you can see the amount of bone that's been lost because of the infection. But unfortunately, like acute pyogenic infection, she's not showing any signs of any ankylosis, any bony ankylosis yet, though there may be a very slight bridge there. But a patient who's got ongoing mechanical issues, ongoing neural issues, you can't leave them that way unless you say no other option available. We'll send you to the pain clinic. So This one we dealt with, I'll be honest, initially by a fixation, and it was only a short fixation from L3 to S1, which failed. And then we had to go back in and realign it and do a posterior, and we had to go to the thoracolumbar junction into the iliac wing. And we did put some cement augmentation for the iliac screws, which we got good hold on. And the plan was to go back and do the operation from the front to achieve fixation from the front. I can tell you honestly, this is not a very good alignment, but for her, she was fine. And by the time we were ready to do the anterior, I think she had some postoperative medical issues. She was discharged home and she had some issues with her hypertension or diabetes, one of the two, which got controlled. And by the time she came back in about 3 months' time, when we were planning to do this anterior stage, we did a CT. And when we did a CT, you could see a good fusion across, ankylosis across L4-5, and we decided not to do anything else. And I just kept following her up. So this was, I operated on her perhaps 11 or 12 years ago. And then she came back about 2 years later. I should have put that X-ray up. And she's fractured the rod roughly at the thoracolumbar junction. And she's got that rod fracture since then. And she's been absolutely fine. We haven't had to take her back. And the rod's been like that for nearly 6 years. I get a Christmas card from her every year, genuinely. I think I might have one coming this week from her. And that's how she is. She's comfortable. She's managing. She's ever so grateful from where she was from a neurological pain point of view and a mechanical pain point of view. Neurologically, she's much better. Her mobility and function has improved so that she's mobile outside the house rather than just be indoors. And mechanically, her pain is far, far better, although she still has some niggling pain, but she says she can live with this. So you go, that's fair. We don't need to interfere and do too much as long as you're happy. And that's what involving the patient in that decision-making process and having that shared decision-making helps, although we were ready to go back in and perhaps do something more to improve a spinal alignment, but we didn't have to. This is another lady who I treated recently. She's only about 1.5 years post-op. She presented with significant right L3 radiculopathy, which just wouldn't settle. And she had multiple injections done for which she had significant improvement. And she's only in her early 70s, pretty fit, healthy, lives on her own, very active and mobile, but significantly disabled with the pain and issues she was having. And she was like knocking on our door repeatedly saying, can you not do something for me? And then we started planning what we could do for her. And we have to realign the spine. So you can see in the coronal plane, she's got a double curve, but more so in the sagittal plane, she's completely flat. And you can see her spinopelvic alignment. And you can grade this as per the Ruseli grading as to what this is. But all the parameters, everything is completely malaligned. And this we did in a staged manner. So not only did we first come in and realign the spine from the front, so we did an ALIF at 3 levels, L5, L5S1, L4-5, and L3-4. And we were going to stage this procedure. After this procedure itself, this lady went home within 48 hours. And she was delighted because when we did that ALIF at that level, obviously we opened up the foramen, the L3 nerve root was adequately decompressed, and her leg pain had improved so much, and she was so happy with it. You know, given a choice, she would have walked away with this and said, I don't want any more because I'm happy. But that's not the full operation. It's only half the procedure that we had done. And then she came back and we did her second stage a month or 6 weeks post-op. And we did a fixation from the back. And this time we've used the S2 AI screws apart from the anterior fixation. So this was more like a posterior tension band. And she's been doing quite well. I had an email from the physio about 3 months ago that she was having some leg pain, etc. And then she had an MR and the MR didn't show anything. She had a CT. All the metal work is good and her leg pain was transient. It had to settle down. So please don't forget that these patients can come back and bite you with something or the other. Be mindful of that. But this lady so far, 1.5 years down the line, has done reasonably well. So just a few take-home points for the lumbosacral lumbar-pelvic stabilization point of view, keep an eye on the spinal alignment. It is very important. If the spinal alignment is not taken care of appropriately, then you are going to face problems where there will be failure. And I think people rely on that lumbar lordosis equal PI plus 9 degrees or lumbar lordosis equal PI. There are different ways of looking at it, but I won't go into too much details of adult spinal deformity correction, but that's a very important point to remember. If you don't get your alignment correct, the risk of failure is very high. Make sure you plan your surgery appropriately. We do have a good, robust MDT discussion in our setup where all these patients are discussed in the MDT. So not only do we get a second, third, fourth, fifth, sixth, seventh, eighth opinion, you got good colleagues who critique things, and that's useful because at the end of the day, you got to have a robust plan, a robust surgical plan, so that you can offer good surgery for the patient to get a good outcome. And more importantly is you have to have the patient in the middle of all this. You have to have a good shared decision-making process. Without that, I would not do these procedures because something or the other happens. And if you have counseled the patient appropriately, if you have gone through the effort to discuss everything with the patient appropriately, if something comes and bites you, all this has been discussed. I'm not saying you go back and say, I said that would happen or I told you so. It's not that. The patient's more aware, the patient's more accepting. Patients are quite understanding of what is happening, why things have happened. So then it becomes easier to tackle those issues because the complication rates for these procedures are high. Whatever anybody would say, some people quote 40%, some people quote 60%, some would quote even higher. So just be aware of these things and be aware that something is lurking around the corner always, and you've got to be very careful on how you tackle this. Thank you very much.
Thank you, Professor Ahuja. It was a very comprehensive discussion about the challenges in this region. Any questions from our speakers? Okay. Yes, Mr. Golash, please.
Sachin, I was just going to means fantastic surgeries, obviously. The cases like the other lady means rather than anterior approaches, do you try the lateral ones as well, like extreme laterals or olives or X-leaf type things?
Yes, absolutely, we do. But getting a anterior fix at 5'1" usually is key because you got to look at the harmony of this lumbar spine, like people talk about it now. That's where the most amount of lumbar lordosis is. The higher degree of lumbar lordosis is more at L4 to S1, where you would like to get reasonable amount of lordosis. And then, yes, higher up, if you want to go lateral, you're going to go olive, all options are open. As I explained, there are multiple options. You can mix and match. You can do whatever is good in your hands.
And a quick second comment, do you routinely do DEXA scans for these patients?
Not really. And there is no hard evidence. Like the adult spine deformity guidelines from BSS are going to be published soon. And all these questions would be answered properly there. But no, we don't routinely do DEXA scans.
And sorry, just to add on to that question, if you find out that this person is osteoporotic, what would be your management? How long would you put them on medication and how long after would you?
No, I agree. If there is any doubt about that, then we do involve our osteoporosis clinician, who's very good. He's very engaging, and he will come into our MDT to discuss things, and he'll draw us a game plan as to what he would think would be appropriate, the duration, etc. So we usually rely on him quite significantly. Like, of course, you would not just operate on patients who got poor bone quality. That's not what I was saying when we don't do DEXA scans routinely. But if you have any questions, any doubts, then you would, yes.
We have two other questions. Can I first ask Lennel to ask his question, and then Kaushik, you can ask next. Your speaker is not on.
Can you hear me now?
Yeah.
Yeah, we can.
Yeah. So, Sachin, we had the same experience with PLIF and TLIF at the lumbosacral junction. You just don't have the disc space clearance, you don't have the surface area, and you don't get the lordosis. Would you say that for an adult reconstructive operation, when you span the lumbosacral junction, an anterior operation is mandatory. That it's not possible to achieve lumbosacral fusion in an adult reconstructive operation.
I can see Rajat is smiling there, big time. No, like, what works in your hand, Lennel, right? And I know the Manchester group have published that they can do a reasonably good pliff. Yeah, if it works in their hands and they can do it, like, what works in your hands, isn't it?
Yeah.
Okay.
We just couldn't make that work. We just couldn't make that work. It's just very difficult.
Couldn't.
Yeah.
I agree. And maybe I couldn't as well. I agree with you. But the Manchester group can. That's fine. But that's the point I'm trying to make. We're getting a 360-degree fix, whether you get it with a pliff or an A-lift or an O-lift, whatever you're going for. What works in your hand safely, where you can get a reasonable alignment of the spine and a reasonable harmony to that lordosis, that's fine, right? How you achieve it.
I was surprised that in that infection case that you got away without doing anything interbody, because you're doing an interlaminar fusion in a highly unstable spine. Basically that's a pseudoarthrosis.
I've not got away. The rod's broken. No, fair point. The rod is broken, but she's fine.
She's asymptomatic. Yeah.
Right. And that's the point. She's been like this. The broken rod's been the case since 2014 or 15 at least. And she's okay.
Kaushik, would you like to?
Yeah, I was going to ask Shashin. I mean, the last case which you have shown, fantastic outcome, very good correction. But as you say, these are very high complication rate operations. I mean, generally, always, most of the literature will quote 40%, and some of them are more. So what is your view in those type of cases who are mid-70s, sometimes they come late 70s, but still can have operation? What is your view about more limited attack on the pain pathology? In this case, you particularly said, I think she was L3 or L4 type of pain she had. So,
I completely agree with you.
Will you select some cases, like I do some cases, just an X-lift of 3-4? In this case, it was so flat, you might need to do another level to achieve at least some amount of.
Kaushik, completely agree with you. Like, patient selections is paramount. The problem is, I'm sure if you do many, you had your fingers burned tremendously. Like, I can show you some of my cases, and you look at that and go, what have you guys done? Right. We tend to do it as two surgeons, all these cases. It's not a single surgeon procedure in our setup. And yes, we have done limited procedures as well. Like, I have done a limited L4-5 on a lady who's got significant rheumatoid arthritis, and she had coronal and sagittal imbalance. And I know you look at that X-ray and you go, it looks awful, but she's doing fine. Like, for her neurological symptom point of view, that nerve symptom point of view, she's significantly better. But that's the problem with this. So each individual is different. And that's where, your patient selection, your discussion with the patient, that MDT discussion, all those things bring things together, so that then you can present a reasonable options to the patient and say, these are the things we can do. These are the risks and benefits. And then you go ahead with what works in your hand.
Thanks.
Thank you. I'd now invite Rajat to actually present a case, just to wrap up this, where he can probably summarize some of the interesting points. Rajat, you can share. Yes, we can see it.
Thank you. So just before we move on, I would highly recommend our paper, which does demonstrate that you can do a complete annular release posteriorly and achieve the adequate lordosis. We've done, I think now close to 170, 175 adult degen cases with exactly the same technique. Now, coming to the spine case, thank you very much for inviting me. I work in the Northwest in Salford Royal Hospital, which is close to Manchester or inside Manchester. Salford is supposed to be a city on its own, but it is all merged with Manchester, and I also work at the Children's Hospital. So this case that I'm presenting is a man who presented to my clinic in 2013, came from a different city in the Northwest, had been touting around for treatment for a while. Fortunately, I think, I don't know, I mean, I think our rheumatology colleagues are getting quite adept at treating this condition. So I don't see as many of these severe chin on chest type deformities. This guy was a smoker. He was depressed. By the time he came to us, most of the time he was using a straw, because if you look at his with him standing on the side, his chin, he was unable to open his mouth enough to actually put food in his mouth. So he was struggling. And this was him from the side, this was him from the back. Now, this type of deformity, or this kind of appearance, clinical appearance, you can see in sometimes due to a lumbar problem or a thoracic problem. But I think looking at his X-ray, I mean, his hips were fine. I had examined his hips. His hips were not ankylosed. But if you look at his, is this projecting okay? Sorry.
Yes, it is. Yes.
So if you look at it, it looks to be a pure cervicothoracic thing, because if you look at the overall, I know the X-rays are not the best quality, but he's a big guy. Difficult to get good X-rays on him. But overall, if you just look at him, it appears that the deformity is mainly around the cervicothoracic area. He has probably got some amount of deformity in the thoracic spine, but not the one that I would say is the primary area of concern. That was his MR scan. His main issue was just eating and not being able to look straight ahead. So he just used to spend all his time smoking at home and doing nothing. So first time I thought it's a heart sink type of thing. You're saying, oh my God, we have to treat this guy, because this guy is, if we don't treat him, he's probably going to either, starve himself to death, or, he's going to fall and then he's going to present with a quadri because he can't see where he's going. So that was his CT scan, which shows the typical, ankylosed spine. This is just some intraoperative. So I think this is as much a challenge for us, and perhaps more of a challenge for the anesthetists. How do they get this chap safely anesthetized in a position for us to operate on? So he came in for a positioning trial, and we've got a very good anesthetic team where they made some bespoke positioning devices to allow us to position him without squeezing too much on his abdomen. I mean, his abdomen is so big that whatever you do, there will be some amount of pressure on his abdomen. And this is just, I got a picture of this done post-operatively, because in spite of spending well over an hour and I think 2 hours trying to position him, still he woke up eventually with a sore after the surgery. So the surgery that he had was mainly a cervicothoracic osteotomy. The osteotomy that we use is, he was done in the prone position with the Mayfield clamps. And the osteotomy is done through, it's like a transpedicular osteotomy through the C7, through the vertebral body, and it's like an opening wedge osteotomy. It is done with full spinal monitoring. It is done, again, we struggle to actually see. One person has to go down and the osteotomy is not completed. You decancellate the whole of the C7 vertebra, and then use the it's not even an osteotome. It's like a blunt instrument which kind of weakens the cortex enough to then crack it open in extension. And this is his image post-op. He was happy, but I think psychologically, with years of this, he required a lot of psychological support. He was very down. He, in spite of a lot of counseling, he was under the misimpression that his neck will start moving after our operation. I mean, I mean, I've recorded all the letters, and but his expectations were too high. But this is something that overall he was pleased with in the end. He did have a cervicothoracic fixation. I mean, going on the theme of what did I do? Yeah, theme of junctional problems. We did do a graduated rod multi-level fixation, lateral mass screws. I tend to use now more and more non-absorbable stitches to repair the fascia, because I think the muscular pull from the shoulder muscles just pulls it apart, and then you just get a big dip in there with the spinous processes sticking out. So I'm very wary of cervicothoracic fixation and repairs, and like it's been mentioned before, I don't leave it to the fellows or the registrars. I try and stay around for it if I don't do it myself. That is the end of the case. Any comments? I mean, I know Angsponds, I don't know. I mean, in our region, we are seeing less of this. I don't know about other regions and what different procedures, Bala, you guys do. Sachin, you got a hand up, sorry.
No, you're right. We used to do plenty of, I'm sure Aprajay, Kaushik would say the same, and Lennel would say the same. We used to do plenty of them. But now with biologics, you're seeing less and less and less of these patients. I had a similar patient, and he couldn't eat. He couldn't even shave. So he used to wear dentures. He used to take his dentures out so that he could do this and shave underneath his chin. And he wasn't as bad at the cervicothoracic region. He was just completely rounded. And we just did a usual lumbar PSO, lifted him up, and he was so much better. And he was so grateful that he could eat, right? It just transformed his life. We were so happy.
Yeah, I agree. Most of them, I think you can change quite a significant amount by doing a lumbar. But this guy, I don't think there was a choice. All his deformity appeared to be across the cervical.
You're right. His thoracolumbar spine looked relatively okay. It was his cervicothoracic where he was dropping down.
Kaushik, would you have a comment?
Yeah, my one comment, which I strongly agree with Lennel and Rajat, is closure. It is so vital important in closure of this, and you see complication after doing all this hard work. You get wound infection and it's all gone. And while closing the fascia, I tend to take bites in the spinous process, if not bony, at least in the supraspinous ligament. And I have found it helpful to keep the fascia together. I still use Vicryl, but a strong one. So closure is of immense.
So what non-absorbable do you use, Rajat?
I'll use anything that comes to hand, nylon, Prolene, whatever. But I need something really thick, and I use because I'll have the sonopet open anyway to do the osteotomy. I use a sonopet to make multiple holes in the spinous processes and just take
Anchor it down. Because we use loop PDS, which works quite good.
Yeah, absorbable.
Yeah.
I mean, those needles are usually quite sharp, and they can most of the time take a bite to the upper part of spinous process.
Your view,
just a comment and view is that did you not consider doing anything from anterior in this patient along with that?
I think in anterior, the way the neck is stuck down there is impossible to access anything. You can't move the neck. You can't get into that space at all. What afterwards? You said after correction?
Yeah.
No, our experience has been that all angsponds that we've done, both lower down and higher up, they all fill up. So this guy, last X, so 2013 he had his surgery. Last X-ray was 2016, and there's no, everything looks absolutely filled out there. He's not a great patient who follows up very well, unfortunately, but you know.
But even if they don't fill up, even just at the posterior aspect, they come up so nicely.
Yeah.
Like, you know, the posterior PLL area, it's absolutely solid.
Sure. I think we just running a few minutes late because it's recorded and the time is specified in the conference. So I think we'll come to an end. Is there any last minute comments from anybody?
Mr. Golash?
So Golash, would you like to say something?
Just to say thanks, big thanks to all the speakers. It has been very interactive. In fact, I learned a few points like we always do. But I can only thank you and Asis and Dr. Badani is just joining. Thank you for all of you to invite us, and I hope we'll have a series of them in future. Thank you very much.
Thank you very much. Thank you for the great discussion, very knowledgeable. And thank you all the faculties for sparing out your time and joining us. We hope we'll see you in person in the conference as well. Thank you.
Yeah, thank you. So I'd like to say officially that, we'll close this session. And I thank, the president, Mr. Golash, who actually is my mentor and I trained under him. I was there in the UK for a very long time and I spent a lot of time with him. So it's been a great, great lecture. I'm sure, there's going to be lots of take-home messages for our viewers in the actual conference. And thank you all. It's an afternoon for you. It's an evening for us. You all taken the time off on a Monday, especially to spend the time with us and share knowledge. On behalf of ASSI, the chairperson, secretary, I'd like to thank everybody and have a lovely evening and a Merry Christmas and Happy New Year to you all.
Thank you. See you.
Thank you very much.
Yeah.
Thanks,
Enjoy your conference. Good night.